welcome to the UPMC Urology Town Hall. My name is Maria Pere and I will be your moderator this evening. A quick background, I went to LSU for medical school, go Tigers, although our defense has been subpar this year. I have 5 adorable nieces and nephews that keep me equal parts happy and equal parts broke. And I'm fortunate enough to be one of the current PGY4s here at UPMC. I'd like to begin by thanking you all for taking the time out of your busy schedules to join us tonight. We understand that during these times of COVID, things are a little different. We're just hoping that tonight you can get to know us and our program a little bit better. There are a few things I'd like to quickly discuss prior to introducing our panel. First of all, this is being recorded live and will be uploaded to our website. So if it goes on for longer than expected, please feel free to leave and you can watch the rest of it at your convenience. We do want to do this webinar style, so we kindly ask that you all turn off your microphones and cameras as we answer all of the questions you pre-submitted. Please feel free to submit any questions you may have directly into our Q&A, and we'll try to answer them later. If we don't get to them, we'll post them on a document in our website. Finally, I'd like to let you guys know if you have any remaining questions or would just like to meet one-on-one with one of our residents, we do have a way you can sign up for an informal, individual 20-minute chat with a resident. You just have to sign up on our website, add one of our PGY4s. We'll copy that direct link into the chat now. And now for our introductions of our panelists. First up, one of our junior residents, Kaylee Gershio, who's one of our PGY3s. She attended medical school at Emory University. She was born and raised in Pittsburgh. In her free time, she enjoys spending time with her husband, spending time with her chickens, and spending time in her backyard with a giant garden, which this resident has certainly benefited from the produce. Next up is one of our chief residents, Avi Maganti. He attended medical school at Cornell Medical College and will be pursuing urologic oncology at the University of Michigan next year. In his free time, he enjoys hanging out with his fiance, playing guitar, being outdoors, and anything sports. Dr. Wasilko is our Associate Program Director and specializes in trauma and reconstructive urology. He completed his urology residency at Northeast Ohio Medical University and his fellowship training at the Detroit Medical Center. Prior to joining UPMC, Dr. Wasilko was an assistant professor in the Department of Urology at the George Washington University School of Medicine in Washington, D.C. In his spare time, he enjoys spending quality with his beautiful wife and 2 children, making pasta, and fly fishing. Finally, we have Dr. Jackson, who is a professor of urology and director of the urology residency program here at UPMC. He completed his residency at Johns Hopkins University. Before joining UPMC, he was head of urology at the National Naval Medical Center in Bethesda, Maryland. His areas of interest include endourology and laparoscopy. In his spare time, he enjoys spending time with his wife and 2 beautiful daughters, swimming and hiking, and hanging out with his dog, Remy. And now for some answers. Thank you to everyone who submitted questions. We hope to get to all of them tonight. We have divided the questions into 2 sections. The first section will be residency-specific questions, and the second portion will be resident life and life in Pittsburgh questions. So I will stop sharing my screen. Did that work? Stop sharing? All right, so let's stop my keys, guys. Did that work to stop spotlight then, Adam? Perfect.
Yeah, looks good.
Okay, so our first question is, what is the call schedule like? Are residents always fatigued while working? We'll start with Kaylee, who is our current actual night float, and then we'll go to Dr. Tuckman for some insight on the topic.
So our call schedule is set up so that we just introduced night float last year. So we have 1 resident that's designated to covering our 6 hospitals from 6 p.m. at night till 7 a.m. in the morning. It's set up as home call, so you just cover at home and go when you need to. I was going to say if you need to, but basically every night you have to because we're covering 6 hospitals. That you usually do 12 nights in a row.
Yeah, I think it's just
that
us.
varies sometimes, and then the weekends are split up among the 10 to 12 residents that are in the call pool, which are PGY1s through PGY3s. So it works out when you're not on night float that you end up taking about anywhere from 2 to 4 call shifts per month, and those shifts are split up throughout the weekends. We do have our call schedule set up so that we have golden weekends, and in general, you have 2 weekends completely off per month, and then 2 weekends that you're on call at some point, not the entire weekend.
And sometimes that's just even like during the day, waiting for the night float person to come back on. So the night float is something that we started again last year. After a couple trials at it or in thoughts at trying it out, then it's really completely a resident organized thing that we've done, and it really turned out well. I think everybody is very pleased. I think that the main advantage is that nobody is post-call when they come in the morning, Monday through Friday, to work and learn and operate, and I think that's a big advantage. Also, a lot more gets done at night, so there's not as many emergencies. So it's really a resident-driven change that's improved the program significantly, and I think that we were worried at first that there was going to be some problems. People were worried, oh, I'm going to, take a few weeks off. I'm going to miss some experience that I could have on another service. But the truth is, I think the increase in the experience on the service when you're there, plus night float does actually have quite a lot of interesting things that go on. Those two things together really redeemed it, and it's been a resounding success among the residents, and the faculty are very appreciative of it as well. I'd like to thank Maria, though, at this point for really organizing this whole town hall. I mean, the goal in these days of COVID is just so that people understand what's going on, what's the program like, and we understand it's hard to do. We had quite 12 people, I believe, that were trying to come in and be sub-Is here, and unfortunately all that was canceled, and I'm very sorry for that, but hopefully you're getting good experiences at home, and again, hopefully this gives you a little bit of a taste of some of the things that we do here, so that you can help make good decisions as you go on.
Great. Thank you very much. So we'll go to our next question, which is a two-part question, but they go hand in hand. How much autonomy do we have, and what does this look like? What sorts of procedures do senior/graduating residents feel comfortable doing independently? We'll start with our chief resident, Avi, and then go to Dr. Wasilka.
So in terms of resident autonomy, I think I would summarize it as that it's more than sufficient, and it is sort of graded and it kind of builds up through the 6 years to an appropriate level that most people, I think, feel is equivalent to being out in practice by the time you're sort of a chief resident. So I think it starts out in 2 levels. First is kind of just clinical duties, and that level of autonomy is sort of built up over the years, where to the point where the chief resident is sort of basically in charge of the services, and the attendings really put pretty much all their trust in them. So that is earned through those 6 years appropriately. So in terms of operative autonomy, that's also something that I think just comes with experience that you gain, and I think the attendings are very good about providing it when needed, and also being able to kind of let you be autonomous when it's appropriate. And I would say that all sort of culminates into a very nice experience as a chief resident at the VA, where you are kind of expected to be the sort of practitioner and the person in charge, where you're doing all the things from seeing a patient to counseling them, to taking them to the operating room, to managing them post-operatively, and then through the rest of their care. So in terms of what we can do, so just by experience, I'm only just starting there, but our experience last year is we essentially did everything, I guess, quote unquote, autonomously, and everything from robotic cases to major open cystectomy cases. So I think most people are quite satisfied with that level that you achieve.
Dr. Silka, any input?
Yeah. Again, reflecting Dr. Maganti's discussion, I think the autonomy in a program, what we have here, is amazing. Starting out at the lower levels and going to the chief levels. First, it starts off as being a 6-year program. It really makes a huge difference, where our 6th-year chiefs, such as Dr. Maganti, in most places, they're out being a junior attending somewhere. They're here, they're able to run an OR, they're able to run a clinic, they're able to run a VA. And that's excellent, because in my theater, in my operating theater, I trust them. They're able to run juniors through complex reconstructive cases. Same thing with Dr. Jackman's endoscopic or doing robotic cases. The chiefs are able to run juniors through. And where you benefit as a chief in graduating, going out in the real world, is where you're able to teach someone. It's see one, do one, teach one. And that's where you really learn to be a surgeon, be a urologist. And that's a huge benefit you have here with the caseloads that we have, the exposure, having a VA. At the VA, we do have at all times 3 residents. We have a junior and then we have 2 chiefs. So major complex cases, the 2 chiefs are doing them together, learning and teaching each other, which is a huge experience and such a benefit. And then on our services, the major hospitals, we do always have a chief where they're running the major cases and most times they have a junior that they're going through with. When we talk about our surgical experience here, I'd say it's as best as you can get in any surgical program or any urology program in the country. Our residents graduate with amazing numbers in surgical cases, and they are able to go out and practice as a functional, excellent attending, even if they don't go into a fellowship that's coming out day 1. And I've had calls from our past residents that have gone out, they've done urethroplasties, their first year out of practice, which that's something you don't see someone who graduates a regular urology residency. And I'm sure Dr. Jackman can talk about the robotic experience and how our residents go out in their functional day 1 afterwards. So it's a wealth of experience in your surgical experience as well as the autonomy and having a large system and having a 6-year program.
And I would say definitely the VA is, I think, where you're crowning a graduation process there, and not just robotic cases and big open cases, but also percutaneous cases. I think Kaylee was just there for the last 3 months. How many percutaneous cases did they do there?
Probably 20.
Probably 20
and
cases.
it was me and the chief and no attendings, like minimal to attending supervision. We were able to run the whole thing by ourselves. I mean, you guys were there and coaching us through it, but we were able to do most of it ourselves.
And this is all with obtaining your own access as well. So it really is, I think, a great program and allows you to get it throughout the whole spectrum of operative experience.
All right, thank you. I will say, Avi's being humble. I know firsthand he can do a Ralph skin to skin, so that's all I will say. This question will have a little bit of overlap, but I do think it's important. So what do we do more than other programs specialty-wise? Less common weaknesses on the trail historically seem to be infertility, recon, and female urology. How does UPMC do in these areas? And we'll go back to Avi and Dr. Silk. I think they have good insight on this.
Sure. Yeah.
Actually.
Yeah, I guess I could speak to how it has evolved over my 6 years at least. I guess when I started, recon has always been strong, largely due to Dr. Silko. And as a result of that, I can probably say that I'm more than comfortable doing most basic recon, even semi-complex recon and prosthetics myself at this point. So I think those numbers are quite excellent. Infertility over the last 3 years has gotten a lot stronger with the 2 new additional faculty members. And, I remember when they started, I had done 2 micro testes at that point, which, very few even fellows in the country have an opportunity to do. So I would say in that regard, that REI experience is quite excellent now. The female experience is sort of maybe not as strong, but is getting stronger with our partnership with the urogynecology department, who actually have a ton of faculty members and are actually more than welcoming of us joining them, which I know a lot of my colleagues and junior residents have been able to do and really bolster their experience in that regard.
And I think you're having an excellent example of what Dr. Maganti's saying. The experience at UPMC, when you travel the trail, and Dr. Jackman and I both know a lot of programs and a lot of friends in the programs, but here at UPMC, we have such a great experience surgical-wise, especially in the subspecialties that were mentioned, the female urology, the reconstruction, and infertility. We actually have designated rotations for the residents that are only on those, where you're spending several months only on female urology. So every day of the week you're doing female urology, clinic and surgical. Our female urology experience is great. We have both the urology female and we have the urogyne, and there's availability for our residents to spend time with both faculties in both departments, which is excellent. For infertility, we have two excellent infertility specialists, Dr. Drakina and Dr. Wong. And then when we talk about prosthetics with erectile dysfunction Peyronie's, I do help with that as well. And that's, again, another isolated only rotation where the residents, when they're on that rotation for 3 or 4 months, that's all they're doing. They're not going and doing prostates, they're not going and doing perks, they're not doing stones, they're not doing other general urology. They're only doing infertility, they're only doing female. And for personal experience, I can tell about reconstruction, you're not going to get a better experience here. I can speak to our graduating, our just now recent PGY6Gs. They averaged, I think, about 30 urethroplasties apiece going in. That's numbers that people don't see in fellowship, and they've only started their chief year. Avi Maganti's run several cases where we have interns, and he's running them through a complete reconstruction. And so it's a great experience. And it's, again, they're all isolated rotations, which is different than a lot of programs have to offer.
Thank you. I did a urethral diverticulectomy today. It was quite fun. Okay, so thank you very much, Seetharam, for your question. I actually think it will, I'll say them both, but I think it'll be answered in our next question, which is, what does the research setup look like? And Seetharam said, what proportion of research is basic science and what proportion is clinical, which we'll make sure and answer. I'm going to start this one with Dr. Jackman, and then we'll go to Avi, since we do it in our 4th year, so Haley hasn't had the pleasure.
Okay. So our research looks different than a lot of places. We're 6 years, but we have 6 months of research officially, if you look at it on the books. But our research experience really starts from the very beginning when people get here, and many people are just excited by the fact that there's lots of things going on. There's lots of opportunities, maybe starting with case reports as a junior resident, and then moving on to whatever interests you. Certainly during your 6 months of dedicated research, you'll have time to work either in a basic science lab, and we have a neurourology lab and oncology labs your residents have worked with, or any lab anywhere at Pitt, actually. Or we also, from a more clinical side, we have a health services research lab with Dr. Jacobs and Dr. Davies. It's been very active recently. So that 6 months is going to be, set aside, but research is done throughout the entire time. Dr. Nelson has really just set the standard for that and encouraged it by incentivizing residents to be able to go to 2 conferences each year. If they get a paper in at some conference, at a national conference, they get to go. And we have times when our biggest problem is figuring out who's going to stay behind. Is 2/3, 3/4 of the residents are going to our Northeast Section meeting, the AUA meeting, the World Congress when it's closer by, things like that. So it's something that people get really excited about. And I think people start doing it, and then the people that get the bug just keep doing it. And just looking at the last 3 years, the people have had more than 10 papers graduating. Even the people that are less interested in going into academics, they just wanted to do some, answer some interesting questions, travel, interact with other folks, and it's a great system. So.
Yeah, I don't have a lot more to add other than kind of echo what Dr. Jackman was saying, in that I guess we're fortunate here that we just have a lot of self-motivated people, and they start doing research kind of from day one. And so although our dedicated time is only 6 months, I think that most of us are, more than productive enough to make that 6 months worthwhile. And I would say all of us kind of extend that to, essentially 6 years of true research productivity. So, and then, I think we're fortunate in that we have established tracks in basic science and health services that it's kind of easy to get involved and get paired with a mentor in those fields, and really hit the ground running with your research time.
And I think that combined with the clinical experience of really being a great surgeon, when you finish, you are a perfect candidate for fellowship, because you can do research, you can write papers, you can operate. And so we get fellowship directors that say, wow, that was a great resident, please send us another resident. And we've had people 3 years in a row going to the same kind of top level fellowships just because they just want another resident that's got that experience on both sides of things.
Great, thank you, Bo. Next question. Is there any formalized mentorship in the department from faculty to residents, from senior residents to junior residents? Start with Kaylee.
So we do have a formal mentorship program where we pair, it's 2nd and 6th years and interns and 5th years. And it's usually 1-to-1, sometimes 2-to-1, depending on how our years work out. And it's formal in the sense that we they're paired up, but not formal in the sense that they're required to do anything specific. It's more that that's their point person for questions. And I know that all of the current chiefs have made and make an effort every couple of months to check in with their juniors and make sure that everything's going well. That being said, there wasn't always a formal mentorship, and our program is very collegial. It's not a very hierarchical program, and we've all made great friends with everybody, and even though you're appointed to one mentor, you end up kind of finding different people for different things that you want to interact with, and I think all of us have great relationships with all of the co-residents. As for formal faculty mentorships, we do not have anything formal right now, but all of our, and Dr. Jackman will talk more about this, but all of our attendings are very approachable, and we go for mentorship for research and for different surgical experiences, and I can't speak highly enough of all of our faculty, that they're all like the most wonderful people to reach out to, and we'll be there to help and answer questions and guide you in whatever direction you want to go.
So yeah, mentorship's always a big concern, and it seems like every year at interview time, I'm always like, well, I wonder, should we have doing something different from a mentorship point of view? And because of that, and then multiple discussions with residents afterwards saying, should we be doing something more with mentorship? The answer from a faculty level has always been, they have no problem reaching out and finding their faculty or several faculty members to work with on various things, as Kaylee said, research and or clinical. So finally, after trying a few different things and people saying it just wasn't needed because it wasn't a problem, we settled on the resident mentorship. Again, another resident kind of driven idea, which seems to have actually worked quite a bit better. I think it's nice to have a chief resident assigned to you as a PGY1 coming in, and then that same person then goes up, they go become a 6, you become a 2, and kind of help you as you transition toward your junior residency time. So I like where our mentorship situation is now, and the residents and faculty all seem pleased with that.
Thank you very much. One more question, our residency specific topic section. How do you envision the department changing in the next 6 years? Dr. Jackman?
So that's always a good question, and the answer is that last year I would have never told you that we would all be sitting 6 feet apart, almost, wearing masks most of the time and doing everything virtually. But our department luckily is able to kind of change and move and be flexible. Right now, no giant major changes are planned that we know of. We've just got finishing in the next year going up to a full 4 resident per year complement. We have our last group of 3 residents in our PGY 5 year now. And they'll be the last group of 3. Other than that, with 4 full residents, we may add one more site, maybe as a senior resident, kind of chief resident, make a private practice type of site, which is something as we increased, we were trying to add, but then our private practice institutions become more academic, and so but they're all different, all of our institutions. So that's really the biggest thing that's going to change is maybe the addition of a chief resident site that we know of. Other than that, I don't know if you guys have any other thoughts about what's going, but nothing really major. We're happy to have kind of stopped our growth, at least at this point in time.
Thank you very much. We have an excellent question from Rohan that I'm going to direct to Avi. Can you talk about the clinic experience during residency? Is there a resident-run clinic?
Yeah, so there is a resident-run clinic, and that's primarily at the VA, and that occurs as a PGY 3, 5, and 6. And it's basically everything from procedural clinic and then to seeing essentially all breadths of urology, general, infertility, recon, and oncology, basically literally everything. And then there's obviously faculty clinics, which you're basically encouraged to attend, and everyone's more than willing to have you. During the rotations themselves, you're basically able to get into a faculty clinic when you're not in the OR. Sometimes that's not as often because we are very operatively busy, and simply put, residents, are required to, need to be in the OR a decent amount of time. But there are many clinics throughout the rotations that we make it a priority. For example, our endo stone clinic, our REI clinic, and at least one of the oncology clinics, and then all the female clinics. That way, you're getting a little bit more of the specialty breadth in there.
And the children's, I believe, the spina bifida clinic that you guys staff as well.
Oh yeah, absolutely. And then the pediatric world is also a little different, but there's a lot of clinic time there, just because we have a bunch of pediatric faculty as well, and then a specialized spina bifida clinic for that too.
And again, I'll again repeat, with us having subspecialty select rotations for the residents, when they're on those rotations, it's not OR every single day, maybe OR 4 days a week, and then there's clinic. And that's when the resident is with the attending, again, on that rotation. So they're seeing surgery and they're seeing clinic patients. So there's designated clinic time for especially the subspecialties. At Mercy, we do have a monthly Mercy clinic where it's the house patients. That's run by the residents, and the faculty do attend that and help out with that as well.
I also want to just emphasize the clinic experience at the VA because I just came off that rotation. Your clinic experience changes from a 3 to a 5 to a 6. As a PGY3 though, you're running in multiple days, I think 2 full days, your own procedure clinic. So you're doing all of the cystoscopies, you're diagnosing bladder tumors for the first time, you're booking them for the operating room, you're then doing their TURBTs, and then you're seeing them in follow-up. You're also taking out stents after you treat people's stones. You feel like a actual practicing urologist, and it's amazing. It's an experience that I think is really unique to our program. And then whenever you become a 5 and a 6, you're, like Avi was saying, your breadth of clinic is a lot broader. So you're seeing a lot more complex patients, but that experience really starts as a PGY3, and it's amazing.
Thank you very much. I will say, as a weirdo that's obsessed with clinic, there's clinic every day and you can get as much of it as you want. So now we will switch to our resident life in Pittsburgh specific section. Are the residents actually friends? Do they hang out outside of work? What about the relationship between attendings and residents? We'll start with Avi, then Kaylee, and then go to the adults.
Yeah, we're friends.
I think we just had a paintball bachelor party for someone here that got beat up, right?
Yeah, for myself included. So
Yeah.
And didn't you guys make a stop at Dr. Taryn's house first?
Yeah.
Sing along.
Yes, we're all friends.
Yes, we all hang out outside of work as well. I have plans with one of our chiefs tomorrow for a happy hour hangout. We before in pre-COVID times, at least once a week, we were all going and getting, appetizers or dinner together, and that was with the attendings oftentimes. And it's whether you're on the rotation with that resident or not, what ends up happening is you work with, a group of residents for 3 months, you all become really good friends, and then you go off to other rotations, and then you end up hanging out still every couple of weeks because you miss them. So a lot of us were just at one of our co-residents' weddings, and we weren't just invited because we're his co-residents, we were invited because we're his friends, and it was COVID time, so they were limited on space. So it's real, it's genuine. I know you guys can't see it like you normally can on the trail, but I promise it's not fake news. We are all really good friends, and including we have really great relationships, like I mentioned earlier, with all of the attendings.
Dr. Selko?
All right, well, I mean, that speaks to a lot, especially when we have our weekly raids of Kaylee's garden for fresh vegetables, right?
Are we your friends, though?
Yeah, well, I mean, we know how to get in our backyard. There you go. All right. In regards to living in Pittsburgh, I'll speak as to someone who just recently moved here, as I was staff in DC, which happens to be maybe a little bit more pricey and a little bit more stuffy. But coming to Pittsburgh, you can still get a nice house or a nice rental for pennies on the dollar compared to major cities. But what's the unique experience is you have everything here that's available that you have at big cities. I mean, we have an international airport. We have daily flights with British Airways to London. So if you want to get away for a long weekend, you have a British Airways direct flight to London. You can fly to, I think we have Germany as well. So we have multiple international flights. Professional sports, if you are into sports, we have 3 of the major professional sports. We have Steelers, football.
They're undefeated right now. It's really exciting. I'm a huge Steelers fan, so I just had to give that plug.
Penguins and Pirates. So we have baseball, hockey, and football for professional sports. You want to talk about the arts, we have the Carnegie system here, which is one of the best in the world for both natural, technology, arts. So it's a pretty cool city.
Restaurant scene's amazing.
Restaurant scene is great.
Um,
Lots of microbreweries.
yes, tons of great breweries. We like to have resident events there.
Yes, happy hours where
Yes.
we go and discuss the cases from the day, or at least something that's interesting.
And speaking as outdoors, as you saw in my earlier fly fishing picture, it's a very unique area where we have mountains, we have rivers, we have trails. If you're an outdoors person, there's so much to do. You can kayak the river right up to the baseball stadium. You can bike from Pittsburgh to DC on a paved trail. You can do running. There's so much to do outdoors wise as well.
There's also Ohio Pile State Park, which is like an hour away. There's Laurel Highlands, which is near there, that has lots of hiking. We're also 2 hours from Lake Erie, 4 hours from DC, less than an hour to parts of West Virginia. For what?
Is that good?
Yes, for hike. If you want to hiking, yeah, it's good. There's lots of outdoor things to do. There's a 24-mile river trail that goes around the city that a lot of our residents will run on to train for the half marathon or the full marathon, which happens every year except for this year. There's lots and lots to do here. Indoors, outdoors, drinking, not drinking, eating. Lots of things to do.
Snow-wise, I think we have 5 resorts within an hour.
Oh yes.
With 5 snow resorts within an hour for
Reasonable
snowboarding.
skiing.
Yes.
And again, my big plug is for the biking. All the old railroad trails that went all along the rivers are now basically turned into bike trails, which is fabulous. And I use them all the time.
And to go back to the affordability of living here, I was actually able to buy a house. And I know a lot of our residents were able to buy houses, I'm technically in the suburbs of Pittsburgh, but I'm 10 minutes from downtown and less than 15 minutes to all the hospitals at essentially all hours of the day, especially now with COVID. And I know a lot of our co-residents also purchased homes. And if you guys have any specific questions as we get closer through this interview trail about what specific neighborhoods, we're happy to answer that at a later time.
I think that brings up the one thing about Pittsburgh. There's nothing that's more than 20 minutes away. It really isn't. You want to go for a ball game, you want to go down to the Symphony Hall, you want to, go for a bike ride. The only thing that's more than 20 minutes away is the airport, and that's about 25 minutes away.
Yeah.
That's about it.
You guys kind of went rogue and started answering all my questions.
We love Pittsburgh, if you can't tell.
So I will reassess here. What about, do any of the residents have children? Families? Kaylee and then Avi.
So neither of us have children, but he has a fiance. I have a husband. I have 13 pets, sorry. I have 8 chickens, 2 cats, and 3 reptiles, which are my husband's responsibility. But lots of our co-residents have actual children that are not animals. And they range from all levels, whether we've had many people in our residency that have had children as juniors, many people that have had them as chiefs, and I wish we had some pictures of all the adorable babies because there's quite a few in the residency program. And yes, it's stressful, but no matter what you do, having a child is stressful from what I heard. I haven't had one, but they make it work and with a smile on their face and enjoy the ride. So it's definitely feasible, and it's definitely not taboo in our program at all.
And there are dedicated, paternity and maternity leave policies too.
I think as of 2 years ago, majority of the residents had a kid.
Yeah.
And sort of like every year flip-flops. Now we're under, but 2 years ago, majority did have kids.
Yep.
Yeah, my co-resident David has 2 beautiful children.
They're adorable.
Okay, so I'm going to cut us off at 8:45, not quite yet, so 8 minutes. So there are some questions that I didn't think we'd get to, but I'm going to go ahead and bring them up. Please, again, this is being recorded live. Feel free to leave. We're going to post it on our website. One of the questions is, what are the perks of the program? Like, what do you get from them? Abby?
Oh, sure. Okay, so like swag.
Anybody with a coat now?
You get a jacket that's branded with our urology department.
It's Patagonia. It's nice.
Yeah. You get iPad or some sort of smart device. You get operating loops, which is really excellent actually.
And we get them our intern year. So you can, when you start scrubbing into Dr. Rosilka's cases as an intern doing your urethroplasties, you'll get in there and actually throw the stitches and everything with your loops.
And then you get all the educational materials. So obviously Campbell's online, which is really helpful too. You get the SASP questions to study for your boards. You get meal tickets, so essentially all your meals here are paid for.
And we never worry about meal tickets. Like, it's not unlimited, but it is. I'm never like, oh, I don't have enough meal tickets. You always have enough. And you also have free parking everywhere, which is huge, because we already, only get paid a certain amount, and you don't want to have to set aside a huge chunk of your salary to pay to park for your job. And that's not an issue here at all.
The other thing I'd say is travel.
Yeah.
We pay for you to go to conferences.
Yep.
If you're a hard worker and you get accepted to conferences, we're going to send you to the conferences, and you do not need to worry about it.
Yeah, at least 2 domestic conferences, and then maybe an international conference, pending the situation.
Yearly.
Yeah,
I mean,
we've had people go to Amsterdam, Paris, Berlin.
I'll say I take
Vancouver.
Every year I take
Cancun.
someone on an international reconstruction
Oh
trip.
yeah, India.
Avi went to Thailand with me. I've
Thailand.
a couple residents to Thailand. I've taken a couple residents to India. So I mean, we do get you out there, and that's something you do not need to worry about.
And we also get a copy of Weeders. We
Oh,
get
yeah.
the yearly AUA guidelines. And we get 3 white coats a year.
I'm due for some.
What's the test?
That's
we give you
18
every
white
year test
coats.
questions.
SASP.
SASP. Yeah.
We do that.
Okay, perfect. There's a question from Aleem with regards to children in residency. Are there affordable on a resident salary childcare facilities available?
So I could speak to a little. I don't have kids myself, but a lot of my colleagues do, and based on what they've said, the answer is yes. They've been able to fairly easily, from what I understand, get very affordable or decently affordable childcare or daycare rather. And not only that, they tend to be like the most ideal daycare locations and facilities, meaning that they're basically right on Pitt's campus. And so basically everyone that has had a child has been able to get their kid into one of those places without much difficulty.
Yeah, I will say specifically, I was at the VA with Anoop and Lee, who both had kids when I was there, and they both used a UPMC specific daycare. So like Avi said, it's literally a block from the VA, and they would they both afforded it easily on a resident salary, and the hours were good for them. Okay, so next, what is the robotic versus open split in your surgical experience? Avi?
Yeah, so I would say, having just interviewed for fellowships as well, I think we're one of the few that are pretty much 50-50. And the reason for that is, we still do cystectomies open, but we still do a fair amount robotic as well. We do many open robotic prostates, but we do also many open prostates, which, at this time is almost becoming a, dying art. But having interviewed across the country, I would say that we're pretty much 50-50, and I don't believe, many other places are about that at this point. I mean, Dr. Jackman might have more insight, but.
No, I mean, I would say I think the open experience here is one of the great strengths. Yes, you don't lose any robotic because you are here for 6 years, but you're coming out being able to do big, more complex open cases, or even if there's something unusual about a robotic case, it can't be done that way. You are comfortable doing it open. One of our fellows who was leaving here, when it was interviewing for jobs, one of the things that they were looking for was somebody with open experience, because the problem is, a lot of the people with open experience are now starting to retire, and they really need to be replaced. And so that was actually something that they were looking for, a fellowship oncologist that was that could do open surgery, and that was quite I don't know, humorous in some ways, or at least made us feel that we're doing the right thing. So I think it's really important to have at least a moderate amount of open experience so you're comfortable with that. And one of the reasons we also have to have that is because having nowhere really around us for hundreds of miles, everything complicated comes here, and there are just complicated cases that have to be done open, or there's no alternatives to. And so that's one of the other reasons we'll see those.
Okay, so we actually made it to the last question. I'm very proud of all of you guys. So the last question is, how do you juggle covering so many hospitals? We'll take it back to our night float. Kaylee.
You just have to do it. That's really it. You just start covering and you learn to prioritize. We have appropriate support systems when you start taking call. So when you're an intern, you start taking an afternoon shift, which is on the weekends, 12 to 6. In the afternoon, and it's only after you've had 3 months of urology. So it's not like you're getting thrown in on your first week of residency ever into taking call. You have a backup resident that is usually ahead of you, either a PGY2 or PGY3, and then you also have a chief on call as well. And basically that support system kind of helps you if you need help with prioritizing. That's basically how you are able to, quote, juggle 6 hospitals, is just by prioritizing what needs to be seen in what order. That being said, I would say even though we cover 6 hospitals, I would say it's the exception, not the rule, that I feel so busy that I'm nonstop running around for the entire shift. That's not the rule. Most of the time, things come in at a slow enough pace or a manageable enough pace that you're able to easily, efficiently see every patient in a timely manner without issue. And the support system is really what helps get you there at the beginning.
And I will add, I don't know if she said this, our hospitals are very close. At 2
that too.
a.m., it takes no more than like 8 to 12 minutes, depending on who's driving. Kaylee, 8 to get from one hospital to the next. And we do have one more question that I think is a very good one. So I know we're very close to 8:45, but I would like to answer this question from Aline. What is the usual breakdown of fellowship residents go on to pursue after training? Similarly, how many immediately go on to practice? Dr. Jackman, I think probably know the exact numbers.
I have the graph that I presented recently. No, it's a little more. I think fellowships has been between 60 and 70% of people going on to fellowship, really for academic reasons, and then maybe 30 to 40% going on in practice. And again, we are very happy to support either one of those, choices. We've had lots of people switch at, last minute and decide, oh, I really do like this. I want to go and do a fellowship. And it's, I think that the great thing about it is coming out of here after 6 years, you're going to be very well prepared to be the best private practice person in your group, and people are going to say, wow, that person's really good, or you're going to be the best fellow that they've had in 5 years, and they're going to be asking for, another fellow with that kind of training.
I think our current graduating chiefs is like a great example of why people choose fellowship and that they don't need to do fellowship. Anoop, one of our chiefs, is not. He's going into private practice. And even at the end of his 5th year, he was like, I feel comfortable doing basically every single case that I would expect to do as a private practice urologist. We have Avi going into oncology because he loves research and he loves oncology, not because he wants like an additional, he doesn't need extra surgical training. We have Kate going into female because she loves female. And then we have Omar going into pediatrics because he loves pediatrics. So it's not that people are going into a fellowship because they feel like they need more training. It's just that they find their niche and want to continue on in it.
And I can also say fellowships coming from here, our residents are going into all fellowships. It's not just like oncology. We have residents going into reconstruction, female, pediatrics, oncology. So they're going into every field. It's not just like one specific one coming from here. And that does reflect the experience that you do get here with the residency, would you say, Avi?
Yeah, absolutely.
Okay, so it is 8:46. Lawrence, we'll answer your question and post it on the website. If you don't mind, we're going to go ahead and wrap it up. I do want to thank you guys all very much for joining us. I know you're very busy. I want to wish you the best of luck on the interview trail, and I really want to encourage you to go to that one-on-one chat session, talk with one of our residents. Anna put the link in the chat for you. So best of luck, and thanks for joining us, guys. Have a good evening.
Thank you.
Thank you.
Thank you, Maria.
Yeah, thank you, Maria.